Hello, good evening. Good evening. This is the Care Fertility Instagram live meeting today. We are going to be talking about polycystic ovary syndrome and fertility treatment. My name is Dr. Rima Rajkhowa, and I am the medical director and I'm a consultant gynecologist at Care Birmingham. So today I hope that we will be able to discuss many aspects of polycystic ovary syndrome and how best we can improve the outcome of fertility treatment. Thank you for joining me today. As we've been live for about a minute now, I think I will start the session. So if you missed the first bit, my name is Dr. Rima Rajkhowa, and I'm a consultant gynecologist and medical director at Care Fertility. And today I am conducting a session on polycystic ovary syndrome and fertility treatment as part of the Fertility Awareness Week. So to start with, we know that 25% of couples who attend a fertility clinic have problems in conceiving because of irregular or absent ovulation. Of these patients, 80% will be diagnosed with a condition called polycystic ovary syndrome. It is a very common condition in all ethnicities, and it covers a very wide spectrum of disorders. Patients may have a very mild form of the syndrome with no symptoms other than an occasional missed period, or they may be at the very severe end of the spectrum with no periods at all, no ovulation at all for years. In addition, it is compounded by problems with weight gain and obesity in up to 60% of women with polycystic ovary syndrome. So it is a common and it is a distressing condition, and we need to have a very, very clear oversight how best to optimize the outcome of any fertility treatment. The first thing that I would like to sort of clarify is there is a difference in having polycystic ovaries as compared to having polycystic ovary syndrome. In about 20% out of every 100 women that we scan, 20 of them, or 20%, will have polycystic ovaries on scan. By itself, it has no significance apart from our management plan. However, in half of them, there will be a symptom such as irregular periods, obesity, excessive facial or body hair, called hirsutism, all of which will then, along with polycystic ovaries, and the symptom will be called polycystic ovary syndrome. So they're two different entities, and one can transition from polycystic ovaries to polycystic ovary syndrome if, for example, you start gaining weight. So these are two different conditions, but one can merge into the other. So, as I said, polycystic ovary syndrome can have a wide range of presentations, including effect on general health, both physical and mental. It can have a lot of impact on menstrual function. But today, if we speak only about fertility treatment, then that would be, I think, important. So as I'm on my own, I'm sorry if it's sounding like a monologue. I'll try and be short, and then I will try and answer questions that you may put across to us by message. Please feel free to send us messages and I will address them as we go along. So, fertility treatment with polycystic ovary syndrome. It is very important to remember that you may have other problems in addition to PCOS. That means there may be a male factor, there may be tubal problems, and more than one factor may be contributing to the difficulty in achieving a pregnancy. So we have to address everything in totality. In a young woman with polycystic ovary syndrome, irregular absent periods, and no other factor, the treatment is very straightforward. We always start with ovulation induction treatment. And that is usually with a tablet. It could be a tablet called Clomid, which we've been using for years, since the 60s, or more recently we're using a tablet called letrozole for ovulation induction. And they are highly effective. I would always reassure my patients when they have PCOS, because they are so worried that they cannot conceive, and they hear all kinds of misinformation from various sources, compounding their worries. And I always say to them that in a patient where you start with ovulation induction, 80% will ovulate and about 40% will conceive within 6 months of trying, provided you respond to the tablet. That means provided you ovulate with the tablet. So if you're taking letrozole and you are ovulating, then continue with the letrozole for up to 6 months if you're young and there are no other factors, because your chances of conception will be up to 40%. If, however, you are not ovulating with letrozole, or there are other factors like a male factor or tubal damage, then you will need more complex forms of treatment, which could be IVF treatment or IVF with ICSI. So how do we at CARE improve your chances of pregnancy with IVF ICSI? It's very important that we, from the very outset, focus on giving you the very best chance of being pregnant at the first time, if possible. This is particularly true if you're young and you're otherwise healthy, and you're prepared to take every effort to optimize first of all, your lifestyle. That means if your BMI is greater than 30, then you have to make every effort to make sure that you optimize your BMI. We do treat up to a BMI of 35, but it is a fact, and it has been shown in lots of literature and studies, that the pregnancy rates can be compromised if you're overweight. So every effort to lose as much weight as possible, and I will come to the strategies for that at a later point in the program. Taking folic acid, stopping smoking, taking vitamin D, and generally having a healthy lifestyle and having a positive hope and aspiration and expectation from the treatment. Now, depending on various factors that we look into before starting treatment, we would maybe ask you to commence an insulin sensitizing agent, such as myo-inositol or metformin. Though the data with metformin was thought to be very robust, it has been questioned a bit now, but sometimes in selected patients I will use metformin before we start treatment to see if we can improve the outcome. This is particularly true if there is evidence of insulin resistance in the form of obesity or very irregular, very infrequent periods. Once we have made the plan for IVF, we usually induce a period, and then we use what we call the antagonist or short protocol. One of the main problems in women with IVF is over-response or under-response to the drugs we use. So there is a danger that despite giving you a low dose, you may produce far too many eggs that then we would like you to produce. Or you may produce hardly any, and we have to increase the dose incrementally, and that can be extremely stressful and difficult. So under-response and over-response, and we scrutinize this very, very carefully by very close monitoring of how you respond. We may do blood tests, we may adjust the dose, and sometimes we do scans extremely frequently to make sure that we give you as best a chance as you can. But despite all of this, you can still over-respond and then have a risk of what's called ovarian hyperstimulation. Ovarian hyperstimulation is a risk for every patient who has IVF treatment, but the risk is far higher in women with PCOS, and it can be quite a serious condition. However, these days, I'm very pleased and relieved to tell you that we have lots of strategies to reduce this risk. And one of the things that we try and do is to reduce the risk of early onset OHSS, and to prevent any other, and to allow you time to recovery, we would probably electively freeze your embryos and then transfer your embryos in a frozen embryo transfer. I'm really proud and pleased to say that laboratories at Care Fertility are absolutely superb, and I have huge confidence in their ability to look after your eggs and sperm and the embryos so that they get to the blastocyst stage and be suitable for freezing and give you exactly the same chance of a pregnancy as a fresh transfer. And that is, I think, one of the critical things that I can say Care will give you for your IVF treatment. So, having gone through quite a lot of things about the treatment itself, I will try and respond to some of the questions that have come through. So the first question is, I think, very important. It says, you have asked me, I have had 3 rounds of letrozole but failed to start ovulation. What can I do next? It is frustrating and disappointing when you don't respond to a very basic and simple, and what I have said is an effective form of treatment. So when you say you have not ovulated, I'm assuming that you have not responded, and an ultrasound scan monitoring or a blood test has shown that you did not respond to the letrozole. We would then call you clomiphene resistant or letrozole resistant patient, and at that point I think you need a review with your consultant and have a fresh look at why you've not responded. Is it because you need to optimize your weight? Is it because we need to go to the next stage, which could be surgical, called laparoscopic ovarian drilling, to help you respond to the letrozole subsequent to that, and that is quite a good strategy. Or we could consider injections called gonadotrophins to boost your ovulation and allow you to have timed intercourse. But if that or you go straight to IVF. Now, which strategy to pick for you will depend on a lot of factors. It'll depend on your age, your body mass index, the male factor, the semen analysis results, and of course also the duration of subfertility, because all of these factors will influence my decision as to which option I would suggest. All options will be available to you, but it would be, my recommendation would be based on all of these other factors. So I think you really need to have a review appointment with your consultant and discuss these factors very clearly and then take action. So the second question I have is very important as well, and it's a difficult one. Is there anything you have found for other patients that has worked in losing weight with PCOS? I agree that PCOS and weight is a constant battle for patients, but ultimately success of treatment depends a lot on your ability to lose that weight. I have had patients with a BMI of more than 40 who have managed to get their BMI down to less than 35, and I think it's great deal depends on motivation, and it is a combination of diet and exercise. There is no one diet which is perfect. I think it's portion control, calorie control, and exercise. I had a patient who went to a boot camp, and she successfully, amazingly, lost a lot of weight. So something like that, along with weight, is what may be helpful, and there is absolutely no reason why you can't do a very intense short form of exercise to help you lose weight without gaining muscle. This is important because, again, weight loss is, and in return, if you do a lot of bodybuilding, muscle strengthening exercises, you may end up bulking up. And so it has to be a good proportionate, and so probably advice from a personal trainer may be helpful if that is available to you. But yes, I think my answer to that, your question, is a combination of diet and exercise and intense exercise. But what is very clear is that very very, very low calorie diets, like less than 1,000 calorie diet, are not good because they don't help. They have acute weight loss and then a rebound weight gain, and it affects the quality of the eggs. That has been shown in some studies. So no, very, very low calorie diets, just a balanced, good, healthy diet, small portions, and good short-term intense exercise regimes. I hope that's helped. So there is another very personal situation that has been that you've requested an opinion. It says that I have PCOS and one blocked tube and a damaged ovary. I had a successful fresh IVF round in 2019 with one of our clinics. But since then, I have had 3 failed frozen embryo transfers and a natural pregnancy that resulted in a miscarriage. Should I be undergoing some tests and investigations to see why all of the frozen embryos failed, or could it be that my body doesn't respond well to the frozen protocol? I think that answer is very, very clear. Unfortunately, PCOS and failed implantations are not, PCOS is not the reason for the failed implantation in a frozen embryo transfer cycle. So you do need some investigations to see why your embryos have failed to implant. It could be planning a fresh cycle and testing your embryos for chromosomal abnormalities by PGTA and then transferring in the embryo, which is normal chromosomally, in a frozen embryo transfer cycle, and perhaps even checking the receptivity window by what's called an ERA test to ensure we're transferring the embryo in the right window, and if necessary, other tests that help called medicated add-ons that we can recommend. So I just want you to understand that please don't be disheartened. It is not the PCOS that is stopping your frozen embryos from implanting, and you probably need to look at it from a different point of view, that there must be other factors that have failed implantation despite that one embryo from the same cohort giving you a live birth. And it is definitely, I think, worth investigating further and looking at a different way of approaching selecting the right embryo for transfer in the right window. I hope that's helped you answered your question. So another question is, what treatment do you recommend for someone with PCOS who has 3 rounds of IVF and produced 2 low-quality day 5 embryos? I empathize with you. It is really, really hard when you've had 3 rounds of treatment and unfortunately haven't had the opportunity to achieve a pregnancy, and the problem seems to have been the embryo grade. I think that sometimes it is not just the PCOS but the overall picture that needs to be looked at. We need to look at your stimulation regime. We need to look at how well the embryos are behaving in the laboratory. Is there any sperm issue that's contributing to the poor embryo development? So it's never always only the egg. It is all other factors that have to be taken into consideration. And I would recommend certainly that if you've had the treatment in the same clinic, I think a review consultation with some fresh eyes may give you a better understanding. And sometimes it may be that this is the situation and this is something then we need to discuss whether there is a chance for improvement or not, and this is something that I think will have to be on a one-to-one basis. So there are some other questions that have come through. I'm just trying to see if I can answer those. Is there anything? Okay, so I'm just going to try and see if I can find those. So I have a question here. It says AMH is 14, which is lower than optimal. Is 14 still a good figure to work with for a successful pregnancy? So in women with PCOS, the AMH is usually, there is no good cutoff figure. So we say that there should be more than 10 or 12 follicles in each ovary. And in my experience, I would say that if the AMH value is more than 30, 35 perhaps in women of reproductive age less than 35 years, I would say that this may be a pointer towards being polycystic ovary syndrome. AMH of 14 in a woman of less than 35 years is normal for your age, so you mustn't be worried about it. It's not, it's, you know, AMH is age dependent, so if you are less than 35, 14 is still a good figure, and I would certainly work with it to go for a successful pregnancy. Please remember, AMH is only a marker of the store of eggs in your ovaries, and it is only a guide for us to know what stimulation protocol we should use and what dose of drugs we should use for your IVF treatment. It does not mean that it will link up with pregnancy. What the most important factor that links with pregnancy is your age. So 14, AMH of 14 in a woman less than 35 or even 38 is excellent chances of pregnancy in my estimate. So best of luck. I hope it will go very well and you have every chance of achieving a successful pregnancy. So there are a lot of questions about dietitians and diet, and I know that this is a tough subject, and on the NHS, to say that there is no dietitian in the West Midlands who can provide a PCOS meal. I think that there are lots of online diet advice that you can get, and I think that, as I said to you, there is no specific PCOS diet that you should focus on. You should just focus on a good balanced diet with not a huge amount of calorie restriction, balanced and smaller portion, combined with exercise, which can be high intensity, to help you lose weight, is what I think has been most successful in my experience with patients. So there is another question here. It says, is type 2 diabetes with a fasting glucose of 8, is the impact with egg quality? And I'm taking glucophage, which is metformin at the moment, but my diabetes is a family disease. So I am not an endocrinologist, so I'm not comfortable answering a question about fasting glucose levels. But what I can say, that with diabetes, type 1 or type 2, it is very important that you have your HbA1c well controlled before you begin treatment, because more than egg quality, it is related to the risk of miscarriage and other problems in pregnancy. So focusing on your diabetic control is extremely important, and I would take the advice from the diabetic nurse specialist or your GP or your endocrinologist to know when it is optimum for you to start treatment. Egg quality is more about age. It is more about how you respond to stimulation, and the diabetic control is very important from your general health point of view, from the miscarriage point of view, and certainly in the obstetric outcome point of view. So I have another comment here. It says, my doctor moaned about my AMH is 17 at 37. Well, I think that's a normal AMH for your age, so please don't worry. You have your ovarian reserve is appropriate for what we expect it to be. So there is another question. It says, can you have a successful IVF course if you still continue to have long-term bleeding even after polyp removed, which come back okay? So I'm assuming that you have PCOS, because the session today is about PCOS and the outcome on fertility treatment. So bleeding problems with PCOS are quite common, and polyp may or may not be the cause of that continuous bleeding problem. So I would say that successful IVF treatment, you do need the endometrium or the lining of the womb to be optimal. And so if you have irregular bleeding during an IVF treatment process, then of course, unfortunately, it can affect the outcome. So it is very important that that has to be looked at clearly before you start treatment. When you mean long-term bleeding, I'm assuming that you're bleeding during your IVF treatment, but if it is in between, it doesn't matter, because the hormones will stabilize the endometrium. There is another comment here which I empathize with. It says, I have PCOS. I've asked for weight loss help for years. nothing worked, including not eating and developing bulimia. I disagree with what you've said. You're under the 900 calorie diet. So of course there are different, no one rule is perfect for everyone. And of course there will be some patients where something else will work better than others. So I would never say that I'm an expert on this, and I would say that you have to find a path that is optimal for you, and I really hope that this works for you and that your weight loss endeavors are successful. There are actually, in patients who are extremely overweight, if diet has failed, I would never want anyone to develop bulimia because of their desire to lose weight. So in that scenario, perhaps a dietitian-led program, as you are currently undertaking, is a good idea. And there are now publications there is research and or case studies being published which talk about even bariatric surgery in patients who have very resistant obesity, with or without PCOS, which is found to be helpful. So as I said, no one size fits all, and it has to be individualized to your needs. I'm just making the very basic first line step recommendations here. I wish you all the very best in your treatment. So we are coming very close to the end of the session today. If you have any further questions, then please feel free to send us a message and we will respond to you directly. And I hope that you found the session useful, and I thank you very much for joining me today. Goodbye.